Critically ill patients requiring oxygen therapy with high-flow nasal cannula, HFNC, and/or non-invasive mechanical ventilation, NIMV, may require nutritional therapy. The decision to initiate nutritional therapy, either orally or by nasogastric tube, is a subject of debate. The paucity of clinical studies, as well as the lack of specific recommendations on nutritional therapy with oral or nasogastric feeding, has generated controversy. In fact, the latest guidelines on nutritional support in the intensive care unit do not address this subject. Patients undergoing respiratory failure may be unable to feed for days, increasing the risk of malnutrition or worsening pre-existing malnutrition. Nutritional therapy in spontaneously ventilated patients is often supplemented with oral feeding, but it is not easy for patients to receive and tolerate adequate levels of caloric and protein intake. The method of choice for nutritional therapy in these patients is the oral route. If this is not possible, then enteral nutrition, EN, via NGF or mixed nutrition may be used. Trophic feeding is defined as feeding between 10 and 20 calories an hour. It minimizes the volume of fluid administered to patients and can prevent mucosal atrophy and maintain intestinal integrity. The primary objective of this study was to evaluate 90-day mortality in well-nourished ICU patients who required treatment with HFNC and/or NIMV and who received early trophic nutrition with a hyperproteic diet administered orally or via enteral NGF. The secondary objective was to evaluate the tolerance, safety, and infectious complications of these administrations. The study diet was nutritionally complete. It was high in protein, low in fiber, and had a reduced fat content. The total volume administered was low when given in trophic doses. When administered orally, the diet was flavored with caffeine-free coffee powder to facilitate food tolerance and avoid interfering with the oxygen therapy modality. The study included 149 patients with high severity scores in 10 ICUs. In total, 110 patients received oral trophic feeding, 36 received NGF, and 3 received mixed feeding. Mortality was low. 22 patients died within 90 days of admission. Similar to other studies on trophic nutrition, this demonstrated that the use of trophic feeding in ICU patients, regardless of their nutritional risk, had no effect on clinical outcomes. Trophic EN was discontinued in only 10 patients due to feeding-related complications. The variables selected for multivariate logistic regression on feeding discontinuation were the SOFA score at admission and urea. There was no significant difference in the development of new infections according to the EN route. Early trophic feeding administered to patients with acute respiratory failure requiring non-invasive ventilation is safe and feasible. It is associated with few dietary and infectious complications in a mortality setting. These results are comparable to similar studies.